Hi, I'm Molly Norton, and this is season 2 of Conscious Mind.
I think that it really works because the patient has all this time with the treatment, but the family sees the patient or gets influenced by the patient's treatment team maybe an hour a day, and they have 23 other hours of the day to fill with how to navigate this experience. And so I think that having other resources is probably incredibly helpful.
You're listening to Conscious Mind.
Today I'm joined by Dr. Mark Russ, and we're here to speak about his new book, The Family Guide to Psychiatric Hospitalization. Dr. Russ is the Chief Medical Officer at Silver Hill Hospital, and I'm also joined by Dr. Amy Swift, Deputy Chief Medical Officer at Silver Hill Hospital. So Dr. Russ has written a really excellent book, and in all the years I've studied psychology, I've actually never come across a book that was specifically written for the family members of people that are being admitted to a psychiatric facility. Were there other books, Dr. Russ, that addressed this as in depth?
There was a similar book in the 1980s, but the field has changed a great deal since then. So the thrust of the book then needed to be updated.
The 80s were quite some time ago.
They were.
I was born in the 80s, Dr. Russ. So, Dr. Russ, what compelled you to write this book? Why now, and why this topic?
Several reasons. One was that I really wanted to have an opportunity to share really 40 years of hospital-based work with patients and families in a way that I could kind of leave behind and that would be of help to families who unfortunately have to hospitalize a loved one. So I thought that I had a unique perspective from a professional point of view. In addition to that, the book contains a little bit of historical information about my own situation. I was psychiatrically hospitalized at age 20. I had 2 brief hospitalizations at that time, which were extremely important events in my life. And I wanted to share a little bit of that experience with families. And the purpose there is really to convey the idea that, first of all, I know what it's like to be in a psychiatric hospital. And secondly, to try to destigmatize the whole notion of mental illness in general, but certainly having been in a psychiatric hospital. It's no small irony that I've spent my life and my career working in and even leading psychiatric hospitals. So I thought that would be a compelling argument in favor of destigmatizing the experience.
Did you decide to go into psychiatry partially based on your own personal experience?
It's a good question. I don't think it was as influential as people might think. I went to medical school with the idea of becoming a family practitioner, more of a generalist, and it was only through my experience in working with psychiatric patients as a medical student that I recognized that this was home. This was something that I felt very comfortable doing, that I felt that I was good at it, that psychiatry enabled me to work both from a scientific perspective, which I was very interested in college as a biology major, but also from a humanistic perspective, that I could use all parts of my brain in trying to help patients. And those were really the more influential ideas. Clearly, my own experience gave me a background in what it meant, and I was certainly helped by terrific clinicians, a terrific psychiatrist, so I knew what that process was about and certainly saw that person as a role model in many ways. So it was a complicated decision in the end, but I think related more to what I enjoyed professionally and what I felt I could be competent in doing.
And are you glad you chose this field?
No question about it.
Okay. That's most important.
Absolutely. I feel blessed. I have had a extremely gratifying career. I have been able to treat patients, treat families, work in academic settings, write scientific papers, do scientific research, and teach a myriad of medical students and residents over many decades. It's really been wonderful.
So may I ask a question?
Please.
Tell us, why write the book to the families and not the patient?
That's a great question. I thought that the perspective would be appreciated and could be appreciated by the family when a loved one was hospitalized, that in the midst of a psychiatric crisis, I did not think that that would be a time where a patient would pick up a book to talk about their experience in the hospital at the moment, that they would be too flooded with emotion and all of the issues that they're grappling with. Families, on the other hand, have a little bit of a distance on that, not necessarily a lot, but enough where they could understand what their role was and how they could be helpful, and so that was the idea.
I think that it really works because the patient has all this time with the treatment, but the family sees the patient or gets influenced by the patient's treatment team maybe an hour a day, and they have 23 other hours of the day to fill with how to navigate this experience. And so I think that having other resources is probably incredibly helpful for them.
Absolutely.
I think the timing of this book, like if I would like to have a stack of these in our admissions department and have every family member that comes in, I want to stand at the door and hand them a copy, because I do think reading this just before or during admitting a family member, it gives you really just concrete tools, and it gives you, it demystifies the experience a little bit and explains some things that people often get really troubled by because they don't have the knowledge or experience to deal with this type of thing. But I want to get into some of the actual meat and potatoes of the book. So it kind of goes through in an organized fashion of, starting at admission and the various stages of inpatient treatment. I think the last chapter is on discharge, which makes sense. So
it actually starts before that in a significant way. The first chapter is actually a history of sort of how we got here, and I raise it for a particular reason, that it traces sort of the modern history of psychiatric hospitals and what's happened in Europe and the United States over the course. But the point that I want to make is that the first example of enlightened hospital treatment came in 1796 in England, and it later became known as moral treatment. And it came about because a woman in York, England, was hospitalized for depression at the York Asylum, which was the only available psychiatric hospital in the area. And tragically, that woman died during the hospitalization. The woman belonged to the Society of Friends. She was a Quaker, and there was a lot of discrimination at the time against Quakers, and her family was not permitted to visit during that 6 or 7 week hospitalization. Had the family been able to visit, it's quite possible that that patient would not have died during the hospitalization. And the impetus of that case was that the Quakers in the area decided to create their own psychiatric hospital, and did it in under very different terms and pretenses around treating patients with dignity, with kindness, and that later became known as moral treatment. So the family and the role of the family was not only important in that case, but really in the history of modern psychiatry and modern psychiatric hospitalizations. So I wanted to emphasize that point, but sorry for interrupting.
That is totally fine. It does set the stage for the rest of the book. So going back to the admissions process and how that is for family members, one of the statements made in the book that stood out to me, I'm going to read the quote directly, is wishing for a medical explanation in the face of evidence to the contrary can lead to a protracted journey of second opinions, alternative diagnoses, alternative therapies, and delays in effective treatment. So this stood out to me because this is something that I've seen a lot in our field when you have a child or a loved one or a young adult with mental illness, especially a first episode of mental illness. There's often a desire on the family's part to find some medical cause. Like, what else could be causing this besides mental illness or a psychiatric disorder? Can you speak, and maybe you can both jump in and speak a bit about this and why that is and how we can help people to kind of overcome that? Because I do see it lead to a lot of unnecessary testing and delay in the treatment that's actually going to work. So how do we deal with this issue?
Sure. Let me preface my response by saying that medical evaluation of patients with psychiatric disorders is absolutely critical, necessary, and because sometimes you do find a medical explanation for aberrant behavior, aberrant thinking, or whatever, and it's critically important that we do that. Having done that, it's important then, if that evaluation turns out to be negative, to let go of that idea and to understand that psychiatric illness is an illness that is no more or less shameful than any medical illness. And I think that people tend to gravitate to medical explanations because, again, of the stigma of having a loved one with an emotional disorder. It creates feelings, could be across the board, guilt, shame, anger, you name it, and people have very, very strong reactions to that. I don't know if Dr. Swift wants to
I think
comment.
also being able to just authentically empathize with the experience, that you can't objectively say this is this disorder or this is that disorder, because we don't have these objective signs like a high blood pressure reading to say this is hypertension or a high blood sugar reading to say this is diabetes. We have to take a constellation of a description of symptoms, sometimes not even things we've seen yet, and say we think this might be this, and here is a recommended treatment if this is this, but say it in a way where we can have them confidently agree that we could try this and we could try to alleviate this symptom that you're describing with this treatment. But it's about being able to join them in saying that the ambiguity can be somewhat distressing, and we understand that.
So that actually takes me to my next point. It's a perfect segue because you talk a lot about relationships and relationships with the treatment team, and I think that's what you're getting at here, Dr. Swift, is the power of that dynamic and that conversation. And it's not necessarily about the content, but how the person feels in the interaction. So, Dr. Russ, you also say in your book the particular relationship between the patient and the treatment team and the family and the treatment team, relationships that are so critical in the outcome of the hospitalization, unfortunately cannot be predicted or known in advance. So let's talk a little bit about the power of these relationships. And even though we may not be able to predict what's going to work, is there anything we can do to better understand some of those elements so that we can teach to it or train people effectively in how to kind of capture some of that magic of a relationship?
Yeah, I think the first thing to recognize, and for families to recognize, is that they are entering an absolutely alien environment, especially in the beginning. That this is an environment that can be extremely frightening for people. People come to psychiatric settings with all sorts of ideas about what they're going to find. So this is a great unknown, and this creates a great deal of anxiety. So I think coming to the situation in some ways with the expectation that this is going to be a very different kind of experience than they're normally used to, in terms of what they're going to be asked, what they're going to be talking about, what they're going to see, is important in terms of sort of establishing certain expectations and preparation for work that needs to to transpire during a hospitalization.
Right. So you have the logic of what to expect and adequately preparing people as much as possible. How do we then manage the softer skills of, and this is something that Dr. Swift is very skilled at. So I'm looking right at you. Not that you're not, Mark, but how do you then take that family under your wing as they come into this unknown, scary alien environment and make them feel at ease?
One of the things that I think is most important is exactly what Dr. Russ said, is that you describe the expectation and then you meet it. So you tell them, this is going to feel very uncomfortable when you first come in. People are going to check on you every 15 minutes, not because we don't believe what you're saying, but because this is the standard practice of our unit. So even if you say, I'm okay, you don't need to, please understand that they're still going to come in 15 minutes later and they're going to check on you. If we tell the family, we could hear that the family's anxious, give them the next time where you might not have any different information, but you're going to check in. Say, I'm going to call you tomorrow between 10 and 12, and then call them. It is the little things that allow them to start to realize that your description of what is happening is accurate, and then they authentically feel that the other things that you're describing are accurate. So if you're saying your loved one actually looked a little bit better today, in the backdrop of having met the expectations you already set, they're going to believe that more. But you have to buy their trust.
Yeah, it's building trust.
Otherwise, they don't. What does it matter if you say that the person they've known their whole life looks better? You met them 5 minutes ago. How do they know you're right?
Yeah.
Yeah, and in building any relationship, the most important thing is to listen, is to not make any assumptions about what somebody's experience is going to be. Obviously, to have with your own experience and knowing the kinds of things that tend to come up, but individualizing it and really treating families as though this is for them the first time, and you respect that and appreciate that, and are not going to simply treat them as another statistic or another patient coming in. For them, this is their world. This is their universe, and they are frightened, and they're counting on us to take care of a loved one. Their expectations may be whatever, but we have to listen to them, and we have to meet them where they are.
Right. And even sometimes, despite our best efforts to do that, there are challenges that come up. And your book does a great job of describing some of the things that, as the patient advocate for the hospital, that I've seen come up many, many times. And one of those things being when patients focus on kind of the limitations or discomforts of the hospitalization as a way of avoiding the genuine issues at hand. I found this part really interesting because you'll see people that get focused on, the food or the quality of, a pillow or something that seems so insignificant compared to the gravity of what brought them in. Can you both speak to that a little bit and how we manage that here?
I often am very direct with patients. I'll say it's much easier to focus on the fact that the bed is uncomfortable than the fact that you were considering taking your own life. Let's talk about why you brought that up, but aren't comfortable speaking about the things that we're really trying to assess and help you with.
So you just call it right out.
Oftentimes they actually really appreciate it because they know what they're doing. And it is difficult, and they want to know that somebody will sit with them through difficult conversations. But I think that those things actually do matter at times to them. They oftentimes say that, how can I feel better in such an uncomfortable place? And then I'll mirror it back to them and ask them and say, do you imagine that this is a place you can recover? Because I need to hear from them that there is a little bit of hope, and then we can start to work and build on that foundation.
And we think about ways that we can improve that for that, like within the realm of possibility, right?
But the main message for the families is this: keep the main thing, that don't lose sight of why your loved one is in the hospital. In this new alien environment, you're going to find things that are going to be upsetting, displeasing, whatever. You may also find things that are, inspiring. That's a possibility too. You need to be open to all of those possible experiences. But it is so easy to derail a treatment situation by focusing on things that may be important but may not be critically important. The goal of inpatient care is outpatient care. The goal is to get the person, your loved one, well enough so that they can engage in meaningful outpatient treatment towards further recovery. And that's the only thing that we're really going to focus on here in terms of the main issues. How are we going to help to have your loved one get better and get back to where everybody wants them to be? So that we'll deal with all of the things that come up. We'll listen to them. We'll try our best to manage them, but let's not let them derail the process.
Right. And it's explaining, I think so much of it is managing the expectation of what inpatient care is and what it isn't. And, the primary focus being on safety, keeping the person safe and getting them stabilized so that they can then participate in more in-depth psychotherapy, be outside of the hospital. It's the highest level of care because of how acute the person really needs to be there. So I think people get in their mind, especially at a place like Silver Hill, where they think like, oh, it's, luxurious and there's a rehab there and beautiful houses. There is still an inpatient service, which is a hospitalization. So I think your book does a really good job of, letting people know of what to expect, because there are those things like 15-minute checks, and that's a regulation. Like, that's every hospital that has an inpatient service. It's not us deciding which patients get that.
And the funny thing is the better the patients get, the less they mind it. Mm-hmm. When they're really acutely distressed, it bothers them. And when they are functioning a lot better, it doesn't become the focus of treatment anymore.
Absolutely. You see that evolution happen. Okay, let's shift gears a little bit and talk a bit about some common misconceptions and kind of myths of inpatient psychiatric treatment. It always blows my mind how the general population really still doesn't know what this is all about and what certain things are and are not. And obviously a big one of those is ECT, right? Electroconvulsive therapy. Most people that I talk to that have no real experience with the field of mental health treatment, or have been lucky enough that they haven't had loved ones at that level of care and need, they say things like, you do shock therapy there? What isn't that? Didn't they outlaw that, years ago? So can we talk a little bit? Can I hear the doctors talk a little bit about what ECT is and what it isn't, and why it's important for people to know how effective it can be?
Sure. So when people think of ECT, they immediately go to the cuckoo's nest image of Jack Nicholson, convulsing on a table, people holding him down and restraints and so on and so forth. That's not what ECT is. That hasn't been what ECT is for the last 60 years, essentially. What it is a method of treating major depression, for the most part, which for properly chosen patients can be 90% effective.
That's a huge statistic. Like
Our
90
meds are 30%.
medications. So psychiatric medications at best are 30% effective. 90.
Can you imagine if you said to somebody, would you like the treatment that's 90% effective or 30% effective?
But
Which would you
how
choose?
many people also are too afraid to try something like ECT because of the stigma and the perception?
Right. So it's, we still do not know exactly how ECT works, which I think adds to the concerns that people raise. Well, you don't really know how it works. Well, we know a lot about how it works in terms of making the same kinds of changes that medication changes, and frankly, that psychotherapy change in the brain. These are just different ways of getting there. The advantages of ECT are that the response rate is very, very high. The time to recovery tends to be brief. That most people begin to respond between the fourth and sixth treatments. Treatments are given 3 times a week typically. So by the end of 2 weeks, a very, very debilitated, ill individual who doesn't see any point in living can have a very, very different outlook. Now that's not true for everybody, but it's true for most people who get ECT. The side effects are relatively mild. We have methods these days of minimizing the electrical current, the charge, the placement of the electrodes, so that issues of memory loss that used to be much more prominent are much less prominent these days. And in our experience, people tolerate this treatment extremely well.
And it's painless, and you're asleep.
The biggest
it is painless. You are asleep. They're muscle relaxants, so you're not having any convulsions that are visible essentially. So it's a treatment that is unfortunately maligned, but extremely effective and very, very useful.
The way I describe it to patients is that the most pain you'll feel is the pinprick of the IV. That you will lie, because I've gone in with patients, understandably, are quite scared. So oftentimes I'll go in the rooms with patients and I'll hold their hand until they fall asleep. And so you have the pinprick. You start to count back from 10, you get to 8, and you're asleep. I've never seen anybody get past 8. And then they put the electrodes on, they put the mask on to make sure that you're breathing. The whole procedure's done within 5 minutes. You see fingers and toes flickering. That's it. There's no big dramatic scene like in the movie, and then you wake up. And when people talk about the memory loss, it is never anything that we objectively notice. They may, during, really in the active course of ECT, they may forget where a pen is or, something
Right.
really
Nothing
minor.
like, I forgot who my child was.
No.
Right.
Yeah.
That's, when you see things that people describe of that, there's probably some contributing factor and you don't have the whole story. But in our experience, our patients do so well with it. And we have people on the other side. I had this one woman that came to me. She's like, I can't believe I fought you for so long on that recommendation. She's like, I wish I'd done it day one, because she felt so much better within a week and a half, that she was like, what was I doing? I've been trying medications for months and nothing moved the needle the way that this did.
Wow.
Yeah, it's very common that patients will come back requesting the treatment, and I think that speaks volumes to its effectiveness and its safety and its tolerability.
Next myth, moving on. So voluntary means voluntary. This is one that, again, over the years, I signed a voluntary form. What do you mean I can't just walk out of the inpatient unit? Talk to me a little bit about that. If there's families listening, what they can expect when a patient is admitted voluntarily to a psychiatric hospital.
Yeah. So these laws vary by state. These are state regulations. They're not a federal regulation that oversees this. So each state is a little bit different. But in general, first of all, we encourage patients to come into the hospital voluntarily for obvious reasons. We want patients who are going to work with us and not against us. But there are patients, because of the type of psychiatric illness that they have, that may not be amenable to treatment right away, and nevertheless still require an inpatient level of care, mainly for safety reasons that we talked about earlier. So if a patient comes in voluntarily in New York and in Connecticut, where we are now, essentially what that means is that should you decide during the course of your hospitalization that you wish to leave, that the process for doing that is to let your treatment team know that you want to leave the hospital. And then the hospital has 3 days, 72 hours, to continue to assess you and make sure that it is safe for you to leave. If after that time or during that time, the treatment team agrees with you that it's okay for you to leave the hospital, then you can leave the hospital. On the other hand, sometimes patients come in voluntarily and then have a change of heart, but still represent a danger to themselves or others, and psychiatric hospitals in this country have the ability to hold patients under those circumstances. Now, patients have the right then to a court hearing where a judge ultimately makes a decision as to whether or not the person can be discharged or is converted to an involuntary admission.
I think allowing somebody to come in voluntarily starts the process as a collaboration with the treatment team, saying we are both in agreement that you want treatment. And it allows us, even if they do put in what we call a 72-hour notice requesting consideration for discharge within the next 72 hours, it allows us to have a discussion about what could be a mutually agreed upon discharge plan that would feel comfortable for everybody. You know, we sometimes will have patients that say, I want to leave because I want to go kill myself. And I'll say to them, you know that I won't be able to accommodate that request. Like this request for discharge under these circumstances, I'm going to have to ask a judge to weigh in because I don't feel as though you're safe right now. But it allows for this really transparent conversation about what they want. Why do they want to leave after they already agreed that we were going to come to a mutually agreed upon discharge plan? And what is changing the narrative for them.
Right, and a patient can become voluntary again after they've
Correct.
come in, but
Often
so
they
the
do.
goal is really always to get the patient to a place where they are there voluntarily.
Absolutely.
So we hear often when families bring their loved ones in, whether or not they say it outright, there seems to be this really, at times desperate hope that we will be able to fix whatever's wrong with their loved one. Please just fix him or her. Can you speak a bit about this phenomenon and how you conceptualize it and how we deal with it as treatment providers?
Yeah. So again, I think that it's not on first blush unreasonable when patients are brought by their families to medical hospitals for surgeries or other kinds of interventions. Patients often are fixed. That when they leave the hospital, or at least shortly after, they're back to where they were. In psychiatry, the illnesses that we deal with are generally somewhat more complex in that they're often long-standing, they're chronic. The process of becoming ill may have evolved over weeks, months, years in some cases, which again is sometimes different than in a medical setting. And the complexities of psychiatric illnesses are such that you need to have a patient as a willing participant and in their own treatment. It isn't like surgery where you agree to surgery and then the surgeon then takes over and does what they need to do. In many of the illnesses, and all of the illnesses that we treat, we're not just treating a constellation of symptoms. We're treating a human being. We're treating a person in the context of a life, of relationships that have ebbs and flows and impinging forces from all ends. These are levels of complexity that don't just dissipate after taking a pill or a couple of psychotherapy sessions. So the idea, which I think is a shared idea, by the way, I think that even as clinicians, we want to be able to fix people. We want,
that is the dream.
Yeah, that is the dream. We share that wish that. It would be lovely if, after 10 days of being in a hospital, that you could come out all better, whatever that might mean. Unfortunately, we know that's seldom true. That's not to say that people don't leave the hospital much better. And one of the appeals of inpatient treatment for me in my career has been that the extent and rapidity of change is enormous in compared to outpatient treatment and so on and so forth. So the notion is not it's understandable, but it's not a goal that that we can generally meet or even very often meet because of all of the complexities. We deal with chronic illnesses in psychiatry, schizophrenia, bipolar disorder, that very often we can make better, but patients can continue to have significant symptoms and significant impairments. And again, that's not to say that they can't live fulfilling, happy lives, but the illness is such that the impact on what the patient's expectations and the family's expectation of what that person might have become or might yet become are compromised. So the idea of fixing people is a great idea. I think because we need patients to be active participants in their own fixing, as it were.
It's a partnership. Yes.
It's a partnership, and families as well. And we dealing with illnesses that we can't necessarily cure.
Right.
So those are the barriers, and those are the challenges for us and for the field.
There are two things that come to mind when you say that. One is oftentimes we see people for inpatient hospitalizations in the beginning of an illness or a crisis where it's kind of a stepwise decline into what their functioning could be. If they've had this absolutely protracted manic episode where it's been months of symptoms, when they leave our hospital, they're still going to be quite symptomatic. And so being able to describe this accurately to the family about the symptom burden that may remain is critical, because the idea that they are going to walk out looking like they did 2 years ago has to be dispelled. Otherwise,
progress is different than...
Exactly.
Right.
They're going to be frustrated. And then the other thing is that we, as the physicians on an inpatient service, have to pull the bouquet of flowers together to show the progress, because sometimes the families can't see it. They are so distraught about what their family member has gone through, what the symptom burden looks like right now, that they can't see that there's a lot of progress.
And the anxiety about what's going to happen next.
Exactly. The
right?
anticipatory anxiety.
Come home. Right.
What is life going to look like for my loved one that just got diagnosed with schizophrenia? Like, that sounds to me, in my mind, like a death sentence. So you, as a physician, have to pull out the bouquets of what actually still is pretty incredible. Your loved one sat through these groups and talked with peers that aren't psychotic, and nobody noticed he was psychotic. And people still rallied around him, even though for you in your family system, he feels very different. So being able to show them that when you're not laying on the floor of the forest, things don't look as dark.
Right.
Can be really important coming out of a hospitalization.
It's a really good point. And Dr. Russ, in your book, you write about a concept, I think related concept of therapeutic futility. And this kind of takes us down the road a little bit, where if you have a family member that has been in and out of treatment many times, you mentioned the revolving door issue, that, there are some folks that may not ever get well or better from some of these more chronic mental illnesses. I want to do something a little bit different here and do a kind of role play to finish out this interview. So if I were a family member coming to you with, a adult child, let's say, who I can't seem to make any progress in helping them to overcome their illness, it feels futile, right? It feels like there is nothing I can do. What would you tell me? And I'm going to start with Dr. Swift. You are going to counsel me for a minute or less on what you would say to a family member in this situation. And then I'm going to have Dr. Russ try the same.
Amazing. The first thing I would say is that we have to remember our roles in life. And oftentimes family members have taken on the role of being mom and physician and therapist and all the things that they think that their loved one and patient needs. And we have to have them step back into the roles that they are good at. Be mom, be supportive, be there for them. But collaborate with the people that can fill the other roles, so that you're going to feel unsuccessful in being the therapist, in being the physician, because that's not who you are. So don't villainize yourself and feel unsuccessful in that role. Allow yourself the grace to be mom and don't try and take on more than bite off more than you can chew.
Well, I already feel better. Thank you. Do you have anything else you want to add to that?
Well, I think that also it depends on the illness, right? If the person is psychotic and unable to executive function-wise make choices that we can understand, that's one thing. If it's substance use and they are just making bad decisions, then at some point you have to take a step back and take the emotionality out and say, if it's a bad decision that leads to danger, there have to be boundaries in place. You don't have to live a dangerous life because a loved one that is a reasonable adult is choosing to. So being able to allow them the opportunity to not feel like they're giving up on somebody, if there is some...
Well, holding the line. Yeah.
Right. If it's dangerous, it's dangerous. If they can't understand the danger, then that's a different conversation. But if it's dangerous, they have to understand that there is a line to hold.
Dr. Russ.
Ms. Norton, you have done everything that a human being could possibly do to help your son. You have been there for him from the very beginning, getting him the help that he needs, bringing him to psychiatrists, participating in family work yourself, being there in the emergency room for the umpteenth time that he needed to be hospitalized. And at the end of the day, you have done everything you can do except make your son do what he needs to do. He doesn't want to be in treatment. He doesn't want to take medication that's been prescribed. He insists on using illicit drugs, substances that make his condition even worse. And no amount of suffering on your part is going to change that. And I know you, and I know that you're always going to be there for your son. So in the event that your son has a change of heart and wants help, I know that you will be there for him. But you also have to be there for yourself and for your family. And appreciate that you can't fix him.
Profound. Both of you. I'm so honored. I'm so honored to work with each of you here at the hospital, and that we have such special, amazing, loving, honestly, people taking care of our patients and their families. Please do read Dr. Russ's book, The Family Guide to Psychiatric Hospitalization. Like I said, I think I'll be handing them out in the admissions building, forcing people to read it. It is a great book. Thank you. Thank you both for being here today, for taking the time to speak with me. I'm sure I will have you back again, and we'll be talking more about a lot of very interesting topics.
Thank you.
Thank you.
You've been listening to Conscious Mind on Silver Hill Radio.